This presentation will cover mild to moderate pain pharmacotherapy with a focus on lower back pain. In this lecture, we will briefly cover the epidemiology of lower back pain, the risk factors, and different options for treatment will be reviewed. The learning objectives of this session are primarily focused around proper drug selection, as based on patient characteristics, patients may require different therapies due to varying properties and risks associated with different medications. Recommendations in this presentation will closely align with the 2017 American College of Physicians guidelines for acute lower back pain. We are reviewing lower back pain because at some point in their lives, 84% of people will have lower back pain. There is only one study looking at the prevalence in Hong Kong. However, this study was deeply flawed, and the 84% is much more likely very representative of the local population. The optimistic news about having lower back pain is that about 80% of people will improve within 7 weeks, with over half improving in under 4 weeks. Of everyone who experiences pain, only about 1 in 3 seek care from the A&E or primary care. This lecture will be focused on and will refer to the over 85% of lower back pain patients that have non-specific lower back pain. Less than 1% of back pain cases are serious causes, like infection or malignancy. And we are able to identify a single specific etiology in less than 10% of cases, including commonly identified causes like vertebral compression fractures, radiculopathy, and so forth. Lower back pain is more commonly seen in patients with obesity, patients that are female or smokers, and a lot of the time, a patient's type of employment can contribute. There is also a higher chance of experiencing back pain in those with depression or anxiety. This list of risk factors is not comprehensive. There are many red flags that would warrant a further investigation that would not be treated with the standard regimens discussed in this lecture. Many of the red flags are fairly apparent, like if the patient suffered major trauma, has HIV, or experienced recent onset bladder dysfunction. Many characteristics of the pain can influence how you decide to treat the pain. More severe pain obviously warrants more aggressive treatment. Do consider asking these questions before making treatment recommendations. Many patients who present to the A&E may have altered mental status or are unable to communicate orally, or may present with signs of substance abuse and drug-seeking behavior. Some signs can help identify whether a patient truly has pain, such as an increased blood pressure and heart rate. Also, sweating, mydriasis, and pallor can be signs of pain. These signs of pain should not be solely used to assess pain in patients. They are only adjunctive assessments of pain. Multimodal analgesia is worth mentioning again, as it is highly effective and recommended in numerous guidelines to use a combination of analgesics with different mechanisms of action to get a synergistic pain relief response. The first thing to consider for treating lower back pain are non-pharmacological options. Superficial heat has the most supporting evidence behind it and should be routinely recommended, although benefit seen is usually fairly minimal. Massage, Acupuncture or spinal manipulation have some low-quality evidence supporting their efficacy in lower back pain, and there are other non-pharmacologic therapies with inclusive data listed here. The second-line option, as per the guidelines, are NSAIDs, most commonly, or muscle relaxants. It is safe to use these two drug classes together. Third-line options include tramadol, opioids, or benzodiazepines. These last-line agents are mostly avoided due to their adverse effect and risk profiles. A drug you may think is commonly used for lower back pain is paracetamol, but a Cochrane review in 2016 and the new guidelines in 2017 have stated there is no additional benefit compared to placebo in lower back pain, and paracetamol should not be used or recommended. However, despite the evidence against its use, you still may see many prescribers using it for lower back pain, as it has been routinely recommended in practice until very recently. If a patient comes to the pharmacy asking for something for lower back pain, paracetamol should not be recommended. NSAIDs are generally the first pharmacotherapy used as long as the patient doesn't have any contraindications to the medicine. The more significant precautions for NSAID use are patients with kidney injury or decreased function, patients with severe CHF or recent cardiac surgery like a CABG surgery, and patients with a history of or an active gastric ulcer. Other concerns with NSAIDs include if they are allergic to NSAIDs or people with allergic asthma. NSAIDs will also worsen about a third of urticaria cases. Other concerns are patients on anticoagulation, patients with hepatic injury, and so forth. NSAIDs work quickly, so you can see the effect while the patient is still in the A&E. Some NSAIDs require prescriptions in Hong Kong, while others do not. In addition to a discharge prescription for an NSAID, often patients may receive a parenteral dose of ketorolac while in the A&E. Topical treatments are another option to consider in patients with lower back pain. Topical NSAIDs have minimal systemic absorption, meaning less systemic side effects, particularly the gastrointestinal side effects. No prescription is needed for the diclofenac or ibuprofen gels. When choosing an oral NSAID, you should keep in mind which ones have lower GI risk, like ibuprofen, versus those who have higher risk, like indomethacin or ketorolac. The GI safety between ibuprofen and the coxibs is not statistically significant. Also, naproxen would be considered the safest NSAID in patients at risk for cardiovascular disease, with indomethacin and the coxibs being more dangerous in this patient population. The next options for treating low back pain are a diverse group of medications lumped together and called the skeletal muscle relaxants. These medications are very common globally, but to a lesser extent in Hong Kong due to the HA formulary not covering most of the agents except baclofen, which is less effective for back pain, and orphenadrine. There is no evidence supporting one muscle relaxant being more effective than the others, besides baclofen and dantrolene possibly being less effective. The side effects are mostly specific to each agent, although they tend to all cause some mild sedation. Many of these drugs are extremely old, so safety data on them is lacking. They are all listed in the Beers criteria, meaning they should not be prescribed in most cases, for the elderly. However, 15% of prescriptions written for muscle relaxants are given to patients greater than 65 years old. Norgesic is just brand name orphenadrine, often combined with paracetamol into one tablet. Although these drugs are in the same class, they are very different with unique characteristics that vary greatly, from not using orphenadrine in patients with glaucoma to chlorzoxazone causing a skin rash. Baclofen is an anti-spasticity agent used more in upper motor syndromes like multiple sclerosis and cerebral palsy, while the others available in Hong Kong are antispasmodics used for peripheral muscle pain and spasm. Tizanidine is unique in that it is effective for both spastic and spasmodic disorders. Several drugs in the class do also cause some anticholinergic side effects, like blurred vision or fluid retention. Most of the muscle relaxants available in Hong Kong provide some pain relief within 1 hour, except baclofen, which can take days to work. Also, all the muscle relaxants require dosage adjustment or should be avoided in patients with either renal and/or hepatic impairment. Although topical treatments are not covered in the guidelines, the lignocaine patch warrants serious consideration for low back pain treatment. The medication is very convenient in that it does not require a prescription and there are no to minimal adverse effects. The side effect rate is usually the same as placebo, with the most common adverse effect being minor local skin irritation. Allergy to lidocaine is extraordinarily rare, as the ester amides are the caine class with the highest risk of allergic reaction. Lidocaine patches have some supporting evidence in various disease states, with the most data for its use in post-herpetic neuralgia. Tramadol is the third-line option for severe lower back pain. It has a few mechanisms of action working on opioid, serotonin, and norepinephrine receptors. There is concern of serotonin syndrome and a lowering of the seizure threshold with tramadol. However, there is less abuse and dependence risk than opioids. You would not combine tramadol with muscle relaxants, as they are both CNS depressants, but tramadol may be combined with NSAIDs. It has a similar onset of action as the NSAIDs and most muscle relaxants. Tramadol also has a more predictable response in Asian patients than Caucasian patients due to its metabolism by CYP2D6 enzymes. It does require renal dose adjustments by spacing out the doses from every 6 to 8 hours to more like every 12 hours. The last options you would see would be the opioids, with morphine being the most common in Hong Kong. They have the obvious limitations that are mentioned in other classes, so they will not be covered in depth here. Morphine has fallen out of favor in many countries due to its histamine release, which causes a decrease in blood pressure and itchiness and discomfort for patients. Fentanyl is much more common in other countries and is much better tolerated and doesn't require renal or hepatic dosing adjustments. If the patient presents with neuropathic pain symptoms, then gabapentin could also be considered. Lastly, benzodiazepines are technically an option, but they have the same efficacy as the muscle relaxants, but with worse tolerability and a significant concern for abuse, addiction, and tolerance, and they should be avoided at all costs if possible. These are the agents that are considered ineffective and should not be used in the management of acute back pain. In summary, this is the guide to treating nonspecific lower back pain. NSAIDs first unless contraindicated, or not effective, then you go to muscle relaxants, with tramadol as a third-line option, and having the topical therapies and non-pharmacologic options to consider as well. These are the references. Thank you for your time and attention.